Hey everybody, Tom here, bringing you protocol of the day. We're going to talk today about ST elevation myocardial infarction, otherwise known as STEMI, and a lot easier to say. We're going to talk about our Delaware State protocols, indications for initiating this protocol, our treatment, special considerations we have when we're dealing with the patient with an acute MI, and what I feel is most important is the difference between your ACS protocol and your STEMI protocol. Your indications for initiating your STEMI protocol are after considering ACS. So we know with ACS, you see a patient that presents with classical anginal chest pain, those anginal equivalents, a full assessment is completed, and then an EKG is interpreted. When you determine on that EKG that a STEMI is present, that's when we go fully into the STEMI protocol. The treatment for a STEMI is the same that we do in ACS. We are providing oxygen, we are providing nitroglycerin, we are providing aspirin and analgesia. The reason we change our strategy with an active STEMI patient versus an ACS patient is even though our pharmacological interventions are going to possibly help relieve some of the symptoms, we are not going to be able to stop that acute occlusion in the coronary vessel, which is causing a downstream ischemia infarct in the cardiac tissue. So when we initially determine that the patient is in fact a STEMI, we are administering aspirin if they don't have an allergy. We are providing oxygen. We are providing nitroglycerin. Again, just like ACS, we have to be cautious with nitroglycerin administration in a patient that is borderline hypotensive or they do not have a history of taking nitroglycerin. So their blood pressure systolically has to be above 150 and they have to have an IV in place before any nitroglycerin can be administered. Now, once an IV is established, we initiate our transdermal paste, the 1-inch nitroglycerin. We also give our 0.4 every 3 to 5 minutes as needed for pain relief and if we see changes on the EKG as we are providing care. A significant difference between the STEMI and ACS protocol is we can immediately initiate our fentanyl dose or any analgesia that we carry instead of waiting for the 3 doses of nitroglycerin in this case, because we know that that occlusion is not going to be resolved by our pharmacological interventions and the patient is in pain. So we want to decrease that cardiac demand that they are having with all of their sympathetic tone that's being initiated at this point due to the pain and the infarct. So we can initiate our pain protocol initially in conjunction with our nitro, which is a big difference between our ACS protocol. Again, with these patients, we have to be concerned about their hemodynamic status at this point because they have an infarct to the heart itself. So we are having hemodynamic compromise and we are giving both nitroglycerin, which is a vasodilator, which decreases that preload, which is going to vasodilate the patient, cause hypotension. And we're also giving fentanyl at this point, which increases parasympathetic tone, which can also cause hypotension. So we have to be concerned with these patients. But what is also more noted in a patient with an acute MI is where is that infarct happening? If we are finding that there's any right side of the heart involvement, we have to be very cautious when administering nitroglycerin. Now, there's a big debate on whether we completely withhold nitroglycerin completely in a patient with an acute MI, especially an inferior or anything on the right side. It's up to the receiving facility and the patient presentation. Every patient presents differently, but it's very common for these patients to also be hypotensive and bradycardic, both contraindications for the other medications that we administer, like amiodarone in case there's extreme ectopy noted, or even nitroglycerin at this point because of the hypotension and the potential for bradycardia. Pharmacologically, we are treating these patients the same as we would with ACS. It's the same procedure that we are going through. We are just faster on administering fentanyl, not waiting for the 3 doses of nitroglycerin. What differs is our pace and where we are transporting this patient. So as I said, this is an unstable patient. Time is muscle. So we are getting this patient as quickly as possible, load and go, to a PCI capable facility, a facility that has a cath lab. So early in our contact, when we determine that the patient is having an MI, we have to give an early notification to the hospital. Now, depending on which county you're working in the state of Delaware, there are subtle differences. Some use a radio communication, some use an app directly on the phone where we can give an early notification and actually transmit the 12 lead to the receiving facility. Either way, depending on which agency you're in and which county you're in, know your procedures for early notification for STEMI in that particular hospital. So once our destination is determined, the hospital is notified, and then care is immediately rendered and being rendered at this point. The patient is a priority one, load and go. So as you are transporting this patient, things to consider is while we are actively treating the patient, we need obviously IV access before any nitro is given, but to make sure, because in case these are unstable patients, so it is in your best interest to obtain bilateral IVs at this point. And depending on your receiving facility, it is also wise to place defibrillator pads on the patient. A couple of reasons for the defibrillation pads, because A, this patient is unstable and they have a high chance of going into cardiac arrest due to their acute STEMI. And it also speeds up the process for once you go into the hospital, they immediately go in depending on the early notification. And a lot of times these patients go directly up to the cath lab within minutes. And depending on your receiving facility and your agency, the cath lab actually uses the same defibrillator pads that you do. I'll show you later on in the presentation. For example, Christiana has a unique placement that the cath lab would like the pads on prior to your arrival. So by you having that done pre-hospital, that just speeds up the process, and it's one less intervention that has to be done for the patient when they arrive in the emergency room. So as we are transporting this patient, we are obtaining adequate IV access. We have placed our defibrillator pads. We are doing serial 12 leads with every intervention that we are doing, because we are tracking both the quality of our interventions, the status of our interventions, but more importantly, we're tracking the status of the growing MI. We want to make sure that we can track that progress, and when we get to the hospital, you can show that to the interventionalists upon your arrival, and they can even further determine what their plan is. And that's why we give our early notification, but then a detailed report is still required to be called in via med control to give your status, what you've done, because that just steers the process for the cath lab team at your receiving facility. So let's do a quick little EKG review, just showing the progression of ACS eventually into a STEMI. So if you look at the continuum of ACS, essentially, your stable angina is all the way over to the left there, and your STEMI is all the way to the right. So like I said, you're stable versus your truly unstable patient. So you may or may not have EKG changes with your stable angina, and then all the way over to your STEMI, that's where you're seeing your hyperacute T waves and your large ST elevations. So as we go through, we know that any type of occlusion is causing downstream effects, so either ischemia or death of cardiac tissue. So we don't want any downstream effects going, but when we do our EKGs, the EKGs are actually looking directly at certain parts of the heart. So quick down and dirty, always imagine your 12 leads as a camera looking directly at where you are placing those leads, and that'll give us an indication of where the lesion is. So another term for a lesion is occlusion. So by looking at your leads, you can determine directly where that infarct is, and it can help steer your care, especially if you are trying to avoid right-sided heart involvement. So we know that our 12 lead broken into our leads shows different parts of the heart depending on where it is, and you can determine which vessels are necessarily included as well. So looking at your 12 lead, you have your lateral leads, your inferior leads, your septal, your anterior, and your lateral. So as you're looking, if we look for elevations first, we can get a determination of where the infarct is. We look for depressions. That also shows how involved the infarct is. So looking at this patient right here, where are our elevations? Yeah, right around here, right? 2, 3 in AVF. We have some depressions in 1 in AVL. So we know that those are our inferior leads where we have the elevations. So what would you name this particular infarct? Yep, acute inferior. So a right-sided MI with inferior involvement, depending on the patient's presentation, this would be one that we would be cautious in using nitro. Let's try another one. Okay, what do we see? Looks like some elevations here, right? V2, V3, a little bit in V4. Oh, I missed the one in V1. Yep, but I agree. Yep. Putting our superimposed, looks like we have some septal involvement, some interior involvement. So what would we name that? Interior septal. So to wrap up with some transport considerations, like we talked about, this is a rapid transport. If we determine that it is in fact an acute MI, we want at least 2 IVs, 2 20s at least. We want to make the patient as comfortable as possible. Because like we said, we're trying to decrease that cardiac demand as much as we can because they are uncomfortable and there's only so much we can do for them pharmacologically. And for the defibrillator placement, like I said, it speeds up the process once they arrive in the ED. And if you look to your right here, this is actually the preferred placement that Christiana prefers. So it's actually upper right shoulder and your normal placement down here. And the reason for that is when they are doing the cath, they are using a device where they're looking directly at the patient in real time. And if the pads are placed in your normal position, it's actually blocking the device from working. So to review, we are treating our STEMI patient the same as we would with an ACS patient pharmacologically, the only difference being that we are giving the fentanyl faster than we would with an ACS patient. All other considerations for these patients is the same except for what facility are they going to. Remember, they have to go to a cath lab capable facility, PCI capable facility, and it is a rapid transport because time is muscle. We'll be going over plenty of EKG interpretation, so don't worry, this was just a quick little overview. But any questions, feel free to reach out. Hope this is helpful and talk to you soon.